Dear ladies and gentlemen, esteemed colleagues, my name is Boris Malugin, and I will be happy to present today the cases of dislocated three-piece IOLs and the surgical tactics of managing these cases. First, we need to assess the incidence of intraocular lens dislocation, and it varies significantly. With the recent studies, the cumulative probability of IOL dislocation is approximately 2% or 7,000 per 1 million pseudophakic patients. There are several IOL types that we are using in our day-to-day clinical practice, which are single-piece, three-piece, and plate haptic. Three-piece IOLs that are dislocated can be managed by IOL exchange, iris suturing, scleral fixation, or combined techniques such as sulcus fixation with optic capture. Here is the case of a patient with dislocated three-piece IOL. This is post-vitrectomy eye, and blue arrows represent the places of sclerotomy. And due to iris suture degradation, the lens was dislocated inferiorly. You can see here the surgical video with the lens significantly dislocated. Both sutures holding the haptical elements were biodegraded. That's why it was a good idea to reposition the lens entirely on the anterior surface of the iris into the anterior chamber. And we will be here planning to exchange this lens for the iris claw IOL. That's why there will be no need to fragment this lens, because we know that artisan iris claw lens is requiring about 6 millimeter length of the incision. That's why we did it sclerocorneal. And here you can see I'm taking this lens, and as far as the lens will be placed retropupillary, you have to be quite sure that the vault of the lens is facing posteriorly. First, we place the artisan into the anterior chamber. Then it is fixated by the special forceps to avoid the tilt and rotation. It is placed into the posterior chamber, and by pushing the haptical elements from behind, we can visualize them and enclave the iris into the gaps of the iris claw lens. Here is the second case of significantly dislocated three-piece IOL that was previously sutured to the iris. One of the haptics of this lens is sutured securely. However, the second one was not because of the suture break. And you can see here that the lens optic is passed through the pupil in order to make the optic capture. This helped us to visualize the haptical element located behind the iris. And I will be using 90 polypropylene to catch this haptical element with the needle of that suture, and utilizing Sipser sliding knot technique with this very nice instrument which is called Condon snare. I have no financial interest in that, but this instrument helped me very much to externalize the loop of this polypropylene suture, and as suggested by Sipser, the knot is tied outside of the eye, and by pulling on both ends of that suture, it is internalized and located now on top of the iris. And this maneuver is repeated several times. Finally, with the 25 gauge scissors, the ends of the suture are trimmed, and you can see here that the lens is nicely fixated and located centrally. When talking about the sutures to be used for IOL fixation, it is not a good idea to use nylon or polypropylene 10-0 because of their biodegradation. Polypropylene 90 can be used for haptic fixation to the iris, and Gore-Tex is to be used for scleral fixation. Here's the case of a patient having decentered 3-piece IOL with corneal scar, myopic refractive error, and Zomering's ring. This patient was operated 7 years prior to admission to our clinic, and as you can see here, the lens optic, which is represented by the white circle, is significantly decentered. Because of the significant myopic refractive error, it is not a good idea to keep this lens, so we decided to remove it. But first, the optics of that lens is cut into 2 pieces, and this is a silicone 3-piece lens, which is a bit slippery and not so easy to cut, so it was necessary to make a partial thickness cut through the optical element, rotate the lens, and to complete this cut to make it full and cutting the whole optical element. So these pieces are removed one by one with fine forceps. The next step, we need to prepare the place for the lens, and because of the significant Zomering's ring, it will be a good idea to remove this secondary cataract because it will definitely impact the secure position of the lens. So one by one, the fragments of the Zomering's ring are removed with viscoelastic and forceps. The cortical material is aspirated, and the 3-piece IOL with the proper optical power is placed into the sulcus, followed by the haptical element to be placed completely into the sulcus, and now optic capture, when the optic is captured by the remnants of the posterior capsule that was being fibrosed over these years, and this optic capture will secure the optical elements and the whole lens. Portions of the capsule are trimmed with the 25 gauge forceps, and this is the end of the case. The other very useful option is to consider sclera haptic fixation, and this was first coined by Gabor Chariot, who showed us that intrascleral positioning of the 3-piece IOL haptics is very secure and provides stable position of the lens. In 2017, Dr. Shin Yamane from Japan published his original technique of intrascleral haptic fixation utilizing the flange that he was created by Cowtree on the end of the haptical element of the 3-piece IOL. Here is the original technique of Dr. Yamane. It is first very important to consider the areas where the haptical elements will be located. After introducing 2 fine needles into the eye, the haptical elements are inserted into the lumen of the needle, and with the movement of these 2 needles simultaneously out of the sclera, the haptical elements are externalized. Following that, the tips of the haptical elements are treated with the thermal Cowtree, as shown here. Following that, the flanges are placed inside the sclera, and this is actually the end of this elegant procedure. Obviously, no technique is immune to complications, and this is a patient having pseudophakic bullous keratopathy after flanged haptic IOL fixation, as blue arrows showing the externalized flanged haptical element eroded through the conjunctiva. Now I try to pull the haptical element with the forceps in order to be sure that these are elements that are connected to the IOL, one to each other, and it was quite obvious that these are two haptical elements of one lens, but not the sutures that holding the implant in place. Here you can see the corneal trephination being done with the disposable trephine, following by cutting the residual portions of the cornea. You can see that the cornea is very thick because this is a long-standing edema. The three-piece lens is being now removed by cutting the haptical elements. They are now positioned on top of the eye. And here is the three-piece lens, which will now be exchanged to the artisan. And this patient was having a small pupil defect at 12 o'clock. And it is worth to mention that artisan cannot be placed in patients with significant pupil defects. However, in this particular case, it was possible to perform pupilloplasty, which is now being done with the 10-0 polypropylene, which is appropriate suture to create a nice and round pupil. The pupillary defect was not very significant. However, after pupilloplasty, it was necessary to form the centrally located pupil with the forceps and scissors, following by slight thermal cautery of the iris, following by penetrating transplant the sutured in place. So there are several take-home messages to keep in mind. First, three-piece lens is obviously the favorite option for complicated cataract cases. There is a variety of three-piece IOL fixation techniques. None of them are immune to complications. And I believe it's worth to master at least three of them: iris suturing, optic capture, and intrascleral fixation, all providing good and stable clinical outcomes. There is no one universal solution for every eye, and it's better to use the technique that you are the most confident with. And I thank you very much for your kind attention.